My name is Gani Fananapazir. I'm a professor of radiology at the University of California, Davis Medical Center, and I'm going to be talking about vascular ultrasound, overview, optimization, and artifacts. So here's an image of the condo I was living in when I was living in Arizona, and it kind of displays my approach to life in general, which is a minimalism approach. I like to have just few things, and the same applies to my approach to teaching, is when you're trying to understand something as complex as vascular ultrasound, what are the few things that we really need to understand so that we can put them together to understand more complex processes? So, what I like to say is the key to understanding lies in organizing the multitudinous facts into a few simple, rememberable, and applicable axioms. And so that's what we're going to do here. We're going to start with visualization. We're going to look at resistance. We're going to look at flow patterns. Eventually, we're going to go into artifacts. And then finally, we're going to put those all together to understand complex vascular pathology. So starting off with visualization, there's really two ways that we can visualize things by ultrasound. One is directly visualizing vessels, and the other is indirectly visualizing vessels. So we'll start with a direct visualization of vessels. Here you can see a grayscale ultrasound of the carotid artery, and you can see the vessel here in the middle of the image here. But we also have other ways that we can directly visualize flow within the vessel. Here's a color Doppler image on the top right. We have a power Doppler image on the bottom left. And then there's a B-flow mode, which is basically a grayscale image representation of flow within the blood vessels. So why not just directly visualize? What's the problem with directly visualizing? Why do we need anything other than directly visualizing the vessel? Well, there's a few problems with it. The color and power Doppler images oftentimes bleed into adjacent structures and can hide pathology. That the image resolution on the Doppler side is not as good as the image representation on the grayscale imaging. Sometimes you have to angle to see a stenosis properly on the grayscale and B mode, which can be challenging. You can have tortuosity of the vessels. The bowel gas and calcifications can obscure pathology. And then, importantly, pathology that is directly visualized may not always be hemodynamically significant. And hemodynamically significant pathology can sometimes not seem significant under direct visualization. So it's important to have both direct and indirect visualization of the vessels. So what does indirect visualization of vessels look like on ultrasound? Well, here you can see an image where we have three components to it. One is the grayscale image, which we can see right here. Then we have a Doppler image where we can see flow within the vessel. And then you can see this gate that's created here with this angle correction. This is the tracing that's depicted from that. That's our spectral Doppler image. And that's how we indirectly visualize vessels, is by understanding the spectral Doppler tracing. So what are the component parts of a spectral Doppler tracing? Well, there's three components to a spectral waveform. Two of them can be seen on the axes. On the y-axis, we have the speed in which a red blood cell is traveling at a particular time. On the x-axis, we have the point in time being interrogated. And so usually that scale is made in seconds. And so each one of those little hashtags is zero point 0.1 seconds. So those are two components that make it up. The third component is how many red blood cells are traveling at that speed at that particular time. And that goes into the brightness of the image. And so the brighter the portion of the spectral of the spectral Doppler image, the more red blood cells are traveling at that particular speed at that particular time. So, uh, moving on to our second topic, which is resistance. There's variability in vascular resistance, which allows blood to preferentially be shunted either towards or away from a particular area. The resistive index is measured by subtracting the peak systolic velocity from the end diastolic velocity and dividing that by the peak systolic velocity. So in this particular example here, the vessel is traveling about 100 centimeters per second. in systole. In diastole, it's about 25 centimeters per second. So 100 minus 25 would be 75, divided by the peak systolic velocity would give us a resistive index, in this case of 0.75. Now, we have various high resistance beds where blood flow is wanting to be shunted away from. That includes resting muscle and fasting bowel would be included in that. And then you have low resistance circuits in which blood is shunted towards those things. So, for example, organs, you're usually always wanting to get forward flow towards the organs. Exercising muscle, we need blood flow to that, so the resistive index is going to go down, and then non-fasting bowel. So let's look at a few different examples of what does resistance look like in different parts of the body. So here we have a representation of the iliac artery, and here we can see a very high resistive index because blood is going here to resting muscle. And so since the only thing that's being perfused here, there are no organs in the lower extremities, it's all going to be high resistance in a resting muscle state. Now, if we move more proximally to the distal aorta, we can see that it has a similar waveform pattern with this high resistance flow, and that's because we're just the distal aorta is predominantly supplying blood flow to the distal lower extremities to muscles that in a resting state is going to be high resistance. Now look at the difference between the distal aorta and when we move to the renal artery. Here we can see that the resistive index here is about zero point 0.5 because you're always wanting to get perfusion going towards the organ of the kidney. And so here you have a lower resistive index. Now, if we move here to the superior mesenteric artery, we can see again that has a high resistance waveform pattern because it's going uh, to the bowel in a fasting state. Now, if the bowel is non-fasting, it's going to move to a lower resistance state. Now, going up further to the celiac axis is a little bit more complex because, yes, it's feeding the spleen and the liver, which is going to be a low resistance pathway, but it also has a slightly higher resistance because there's going to be an area where you get involvement of the left gastric artery. And so there's going to be bowel perfusing that. So it's going to be a mix of some low resistance and some high resistance pathways. So it's going to be much more complex. And even more complex than that is going to be your proximal aorta, which is now going to be supplying not only the spleen, the liver, the kidneys, which are low resistance pathways, but also the higher resistance pathways of the bowel in a fasting state and the lower extremities, the muscles that make up the lower extremities. So it's going to have a complex pattern that's going to be additive of all of the areas that it's going to be perfusing. And so just to take a look at that, if we compare the proximal aorta with the distal aorta, you can see the slightly lower resistance pathway of the proximal aorta because it's also including the resistance, the lower resistance pathways of the organs, whereas the distal aorta is only going to be supplying your lower extremities and is predominantly going to be muscle involved. So let's move on to the third important pattern, the third important part that I think is important to be able to understand vascular ultrasound and spectral waveforms is the three flow patterns that we see. One of them is going to be plug flow, one of them is going to be laminar flow, and the other is going to be turbulent flow. So if we understand these three flow patterns, it really helps us out. So what is plug flow? Plug flow is when all of the red blood cells travel the exact same speed at the exact same time. Laminar flow, on the other hand, oh, and then, sorry, the spectral Doppler waveform of this, since everything is traveling at the same speed at the same time, that's going to lead to brighter spectral waveform pattern. Because remember, the brightness indicates how many red blood cells are going at a particular speed at a particular time. And you can see this narrowing here of the window is because everything is traveling at the same speed. So you can kind of, with the spectral waveform, trace this out with a pencil. Now, laminar flow, on the other hand, is when there's faster velocity in the center of the vessel and slower on the edge because of the resistance supplied by the wall or the edge of the vessel. And so blood flow is going to look like this, where the center is going faster and the periphery is going to be slower. It's kind of like when you walk into a river, in the big, in the edge of the river, there's not a lot of flow that's happening, but then as you go deeper and deeper, you can feel the current. And so a similar thing happens within vessels. And what that means is that rather than being able to trace this out with a pencil, now this is more like a Sharpie. It's a thicker line that you get that you have to draw here. And that's indication of laminar flow going on within a blood vessel. And then finally, turbulent flow is velocity. Red blood cells can move at any velocity at any particular time. And we can see this complete filling in here of the spectral window. We've just had to kind of fill in the whole entire thing um, with um, spectral flow because everything is going at different speeds at different times. Now, we can have different flow patterns that we can see within the same vessel. So if we look at the very center of a vessel, and this is on the carotid artery, we can see here that this is probably plug flow here that we can see in the very center because most of the blood is flowing at the same velocity at the same time. Whereas if we look at the edge, if we put that spectral Doppler gate over the edge of the vessel, then we can see that it becomes much more of a turbulent flow pattern because of all the red blood cells that are interacting with the edge of the vessel. And we can see all three waveform patterns normally. Plug flow is normal to see in large vessels. Laminar flow is normal to see at the edge of vessels or within small vessels. And turbulent flow can normally be seen also within bifurcations, tortuosity, and also at the edge of the vessels as well. So let's go over some artifacts that are important for understanding what's going on within vessels. Aliasing is one of the most important artifacts to identify. And aliasing is basically the inaccurate display of Doppler velocity when the range exceeds the scale available to display it. So for example, in this particular image here, blood is flowing towards the left. And so in that particular state, we should see everything going in one particular color. But because in the edge of the vessels, things are traveling slower than in the center of the vessels, sometimes if this particular um, uh, scale here is not done appropriately, then if it happens to be going more than negative 30 centimeters per second, then the only way that it gets depicted is by becoming blue. And so in this particular case here, because the scale is incorrect, therefore the center of the vessel is actually traveling more than the negative 30 centimeters per second, and it has to be depicted by being blue. So it's not scaled correctly. So aliasing also exists in spectral Doppler, and this is an example here where, similar to what we were seeing in the color Doppler image, in here it looks like once you get to about 45 centimeters per second, what happens here? The way it gets depicted is because the scale is not set appropriately, it gets depicted on the other side here. And so you can see that aliasing can occur both within color Doppler images and also in spectral Doppler images. And so what you have to do in these cases here is just adjust the scale. And so here you can see the scale went up to about 45 centimeters per second. Here we just adjusted it to 60, 70 centimeters per second. And now the whole entire waveform is able to fit in there and it doesn't alias on the spectral waveform. Now, vibration is another artifact that's important. Vibration is picked up on Doppler because Dopplers are just looking for movement or motion. And so, if there's something that creates vibration within the tissues, it's going to show up as color Doppler image. And so, here you can actually see this massive amount of Doppler signal within the central portion of this kidney is because there's a vibration there that's caused by some pathologic process that's causing all the tissues to vibrate. Now, this can also actually be picked up on a spectral Doppler window, especially when you have laminar or plug waveform, where you have this nice clear window underneath. And here you can see with every systolic peak, there's this kind of low amplitude signal right under the systolic peak that indicates that there's soft tissue vibration going on. So here's another example of an artifact that you can see both on the color Doppler as well as the spectral Doppler waveform. So, what are the different approaches that we've looked at so far? We have direct visualization, we have indirect visualization, we have resistance patterns, we have flow patterns, we have vibration artifact, and we have aliasing. And if you have those six components, you can understand a lot of the pathology that we see on spectral Doppler imaging. So let's take a look at some of those very common pathologies within vessels. Arterial stenosis is one of the common pathologies that we can see. And what happens here is a number of different processes. One of them is that as you're getting through the stenosis, you have to send the same volume through that narrower area at any given point in time. That same amount of blood has to travel. And so what happens to the blood? It actually travels much faster. And so you get high velocity right at the area of stenosis. But the other important artifacts that we can see is one is vibration can be created from this. So we can see vibration both on the color Doppler, but also on the spectral Doppler waveform. And then also the waveform pattern changes. In the beginning, that we may have in a smaller vessel, maybe in a renal artery, you have laminar flow. Then when everything gets to the area of stenosis, it changes to plug flow because everything is forced to go at a particular velocity. And then more distal to that, you get turbulent flow. And so those are the three waveform patterns that I think are important to be able to recognize. So here's an example here of laminar flow. Here you can see a little bit of clarity under the spectral window. When we get right to the area of the stenosis, here we can mark it out like a pencil, the waveform pattern, and we can also see this area of vibration artifact on the spectral window. And then look what happens to the velocity. We're going from 100 centimeters per second all the way up to about 900 centimeters per second at the area of stenosis. And then what does it look like distally? Well, here we can see complete filling in of the spectral window, and so this is a turbulent waveform pattern. And so these are what you see in stenosis in anywhere in the body. So let's look at a few examples. Here's a transplant renal artery stenosis. Let's look at these different images here. So we'll start with the top left. We can see this color Doppler image here. We can see some aliasing going on right at the origin of the renal artery where it's turning blue right here. But we can also see this vibration artifact that's created because of the turbulence from the stenosis. Looking here on the proximal renal artery, we can see very high velocities. Here we actually have aliasing going on within the proximal renal artery, but if we look under the window here, we can see this vibration artifact occurring pointed to by the arrow. You can see it a little better when it's fixed, when the spectral waveform is fixed. When we've increased the scale here, we can see plug waveform, high velocity, vibration artifact, and then we go more distally in the renal artery and we see this turbulent waveform pattern here. And so this has all the hallmarks of a transplant renal artery stenosis. Now, here's another example here of carotid artery stenosis. It's going to have the same pathology. Here we can see probably laminar flow right at the area of stenosis. We can see this vibration artifact occurring during systole. And then what happens when you go more distally? We can see this choppy, filled in spectral window. This is the distal turbulent waveform pattern. Here's another example of superior mesenteric artery stenosis. Again, similarly, we're changing our waveform pattern here from maybe laminar or plug waveform to a turbulent waveform pattern, and you have an area of high velocity. And then, sure enough, if you look at all of the systolic peaks, we can identify that there is indeed vibration going on there as well. Here's another example here, superficial femoral artery stenosis. Again, the same pattern where you get high velocity. plug or laminar waveform right at the area of stenosis, and then we have this vibration artifact, and then we go more distally and we see this turbulent waveform pattern. So let's move on to another common pathology, which is arterial venous fistulas. Uh, these are basically a connection that's made between the artery and the vein. So here's an example here of a biopsy needle that's now entering between the artery and vein. We've now created a connection between those two, and the direction of flow now gets preferentially shunted away from the artery, which has a higher resistance, to the vein, which has a lower resistance. And some flow may go distally, and then, of course, in the vein, you would still get flow coming more proximally. So arteriovenous fistula demonstrates aliasing, high velocity at this area of connection. There's going to be a lot of vibration going on from this particular fistula. You get the Bruy sign, and there's going to be a low resistance waveform of feeding arteries into the fistula and arterialization of the flow that ends up within this proximal portion of the vein. So let's look at some examples of here. Here's one where there's a liver biopsy that was done. After the liver biopsy, we can see on the Doppler image that there's areas of vibration artifact going on here. And if you put a spectral waveform on there, what do we see? We see high velocity, low resistance waveform pattern. Here's a kidney transplant that has an arterial venous fistula. If we put on the Doppler, we can see that there's this area of tissue vibration that's going on within the kidney transplant itself. You put the spectral waveform on this. It's a high velocity, low resistance waveform pattern that we would expect. And interestingly, if you look at the feeding artery, we can see that this is a low resistance in the feeding artery. This patient actually had two transplanted renal arteries. And if you look at the other transplanted renal artery that was going to the unaffected portion of the kidney graft, we can see this higher resistance pattern. So low resistance, high velocity, vibration artifact. Start thinking about an arterial venous fistula. Here's another arterial venous fistula that's in the femoral artery. Here we can see on the Doppler image, every time there's systole, there's tissue vibration that also goes on there, indicating that there may be some pathology going on. Here's a nice indication of the feeding vessel. It's this tiny vessel that's going into this arterial venous fistula. You can see it on B flow. And what do we expect to see? A high velocity, low resistance waveform pattern, which we see. And then if we go into the vein itself, we can see arterialization of the venous waveform. This doesn't look like a venous waveform, even though it is it is the vein. But that's because the artery is feeding into there and giving it an arterialization of that venous waveform. The final pathology we're going to talk about are pseudoaneurysms. These ones have vibration artifact. Again, there's tissue vibration that happens, and you get this to and fro flow on spectral and colored Doppler image. And so why is that the case? Where a pseudoaneurysm is basically a contained vascular rupture. So here's the blood pouring out of a blood vessel. Something ends up containing it, whether it's a hematoma or some adjacent structure. And then the blood that flows into the neck of the pseudoaneurysm ends up circulating around and then coming around the other side, and I'm just depicting it as blue because it's now going away from the ultrasound probe and then goes back into the vessel and goes out. And so it has this kind of swirling pattern within pseudoaneurysm. So let's look at a femoral artery pseudoaneurysm. Here you can see the neck depicted right here. Here's the femoral artery, and then this is the pseudoaneurysm that you can partially visualize. And so what ends up happening is during systole, there's going to be arterial flow entering into the pseudoaneurysm, and during diastole, it's going to go back out. And so what you're going to see is this alternating red and blue, indicating blood going into and out of the pseudoaneurysm sac. And when we looked at that on spectral Doppler image, here again we see this flow going into and out of the aneurysm sac when you put it right on the neck. And here's a beautiful depiction on B flow, just to show Here's the neck right here. Here's the femoral artery. And you can see the blood flow swirling within the pseudoaneurysm itself. So here's a hepatic artery pseudoaneurysm or a hepatic pseudoaneurysm. Here the liver was biopsied. There was this collection that was seen post biopsy, and sure enough, we can see this yin-yang sign, as it's called in for a pseudoaneurysm, where blood flow is going towards and away as it's swirling in there. So it gives us this red and blue appearance within the pseudoaneurysm sac. And then here's just a CT that's just showing confirmatory that yes, indeed, there is a pseudoaneurysm within the liver itself. What does a renal graft pseudoaneurysm look like? Well, similar to any other pseudoaneurysm, here we can see on the Doppler flow, if we pause it right here, we can see that there's that yin-yang sign within this collection right here. It's got that red and blue indicating to and fro flow within it. Here we can see it on B flow. It becomes much more pronounced on systole, obviously because that's when the flow is most pronounced within a pseudoaneurysm. Here's direct visualization of an extrarenal pseudoaneurysm. You can see outside of the kidney graft here, there's this collection uh, that's um, that's medial to the graft itself. And then that one, when we looked at on B flow, we can again see that swirling that goes on within there that's characteristic of a pseudoaneurysm. So that's really it. So just to summarize, we have direct and indirect visualization together are important to be able to make the diagnosis. 'Cause not all of the information is given to us from direct visualization. It's important information that we get from the spectral waveforms. It's important to know the different resistance patterns of high and low resistance, to know the normal flow patterns of plug, laminar, and turbulent, and when that's normal and when that's abnormal. Notice the artifacts, especially I think aliasing and vibration are the two most important artifacts to know. And then look for common pathologies, the stenosis that we went over, arterial venous fistulas, and pseudoaneurysms.